Remember, we said it's named for whichever component is most expanded, and this is expansion of the red cells. Generally, you see a very high hemoglobin hematocrit. The last one I saw was literally 20 for a hemoglobin. And you do generally also see some expansion of the other cell lines as well. So their white count will be up a little bit, their platelet count will be up a little bit, but in general, not nearly to the proportion and degree that their red cell count is up. The classic thing here is that the red cells grow without erythropoietin. So they don't need erythropoietin. You can put those colonies in a petri dish and watch them, and you don't have to add anything to them. They'll just grow all by themselves. Generally, again, this is an older patient population. And one of the symptoms that's kind of related to P. vera is that aquagenic pruritus. I know, you know, the hot shower, the hot tub, your patients will no longer take a early hot tub bath or whatever because they itch intensely. And that's very classic for P. vera. Usually what you see with P. vera is plethora, so there'll be kind of that ruddy color, and if they get high enough, they'll almost kind of have a bluish tint to their lips and kind of a bluish purple tint to their fingertips. They will occasionally have splenomegaly. Occasionally they'll present with thrombosis because they sludge. You get pretty hyperviscous as that count goes up. And then also patients will present with symptoms of gout because this has got a pretty high turnover. Another symptom that's kind of unique to P. vera is erythromelalgia. And this is painful redness of the digits, primarily the hands, sometimes the feet. We don't really know why they get it, but they'll get really red and really tender. We also see peptic ulcer disease with P. vera. And all of those things are thought to kind of result from the increased histamine. You got increased basophils, and probably from the increased histamine release. How do you diagnose somebody with P. vera? Well, you've got to have an elevated hematocrit and hemoglobin, but not everything that has an elevated hemoglobin and hematocrit is P. vera. So you've got to have a few other specifics. You need a normal PaO2, so you're trying to rule out cardiac and pulmonary causes of secondary polycythemia. And then you would want to see maybe one of the physical findings such as splenomegaly, and then now a low serum erythropoietin. That's been added to the criteria now, and so a low serum erythropoietin is classic and is a hallmark for primary polycythemia. Other things that you may see, that elevated platelet count, that elevated white count, you may see an elevated LAP, so and opposed to CML where it's low, this one will be elevated. And sometimes you'll see an elevated B12 or B12 binding capacity. The primary thing, however, is that you have to exclude all those secondary causes. And you know, there are a ton of secondary causes for an elevated hemoglobin and hematocrit. The biggest ones would be, you know, cardiac disease, pulmonary disease, smokers, emphysema, so anything that makes you chronically hypoxic. Things like renal cell tumors, as a perineoplastic syndrome will secrete erythropoietin. Cerebellar hemangiomas will secrete erythropoietin and give you a secondary rise. So some of the malignancies. And then Guy's box is on here. Anybody know what Guy's box is? Stress polycythemia or spurious polycythemia. It's initially described as that kind of type A personality, a little hypertensive, overweight, middle-aged man with a type A personality is how it was described, and it's really a contracted plasma volume that falsely elevates your red cell mass. So what does P. vera do if you diagnose somebody with P. vera? It's usually a very slow and indolent disorder. It progresses on, though, to either acute myeloid leukemia, so it can turn into AML. It can progress on to what's called a fibrotic or a spent state, so you just have replacement of the bone marrow with fibrosis. So usually one of those two things happens if you follow somebody long enough with P. vera, but it takes years and years and years for that to happen. Treatment options for P. vera are pretty easy. Phlebotomy, they've got too much blood, just phlebotomize them. It's pretty easy to do. You can do it often initially. You make them iron deficient by phlebotomizing them, and then you just have to keep them iron deficient by phlebotomizing them every so often. If they don't tolerate phlebotomy, you know, the 300-pound man that faints every time he sees a needle. I've got one of those. Or, they've got pretty bad carotid disease or something, so they don't tolerate having their blood volume removed. Then you can use some drugs to help control those. The drugs that we use are things like hydroxyurea or busulfan, which will give you suppression of your blood counts. We also use those drugs if we need to help control things like platelet count, to try to control more than one cell. The other thing you can do is you can add low-dose aspirin if they don't have any contraindications, because that helps with some of the side effects and helps with that propensity to have blood clots. All right, ET, essential thrombocytosis, by definition is an elevated platelet count that goes over 6 months that has no other explanation. So high platelet count without any other reason for it that's long-lasting. Sometimes you may see splenomegaly, but these spleens are not usually that big. And there's not a diagnostic test for ET. This is strictly a diagnosis of exclusion. So you got to rule out everything else, and then sometimes you still don't know. Reactive thrombocytosis. Most common cause is iron deficiency anemia. So you need to make sure they're not iron deficient before you call them having ET. The other things that we see that will give you a reactive thrombocytosis, malignancies, collagen vascular disorders, any sort of chronic infection, somebody that's had their spleen out. Those sickle cell patients that have kind of autosplenectomized, they all tend to run a little bit higher platelet count. And then the other